Good morning, everyone. It's a great pleasure to see you all on this day in this nice place and in this nice city. And I hope you enjoy your stay and take from this course as much as you can. It would be much too much, especially my things today and tomorrow. But I hope that it's not too easy and not too difficult. I'm supposed to say something about myself. It's the most difficult thing to talk about yourself. It's not quite easy, but I am a radiologist since about 20 years. I came from Syria before about 30 years to Austria, and I worked at that time day and night in order to learn German, in order to learn radiology, in order to learn everything, in order to make scientific work, in order to teach, and everything at once. It was hard time, but it was okay. And this is the evidence, you know. It worked. When you work hard, you are going to find it in the future. This is simply, and also radiologists or doctors have to work too much in order to be good. From not doing is not going to be good. And also seeing and learning. Okay, now I'm working in Vienna in the Department of Neuroradiology as a neuroradiologist since many years. And that's why my talks are going to be majorly about neuroradiology and not general radiology. And first of all, back pain. Back pain is a general thing. It's one of the most common symptoms doctors see, or even people have in this society, but it's still a problem, you know. I have also a problem here. I don't have a screen. I'm going to share your screen with you. And there is a little bit a problem because it's very, very common thing, back pain. And imagine you are now a radiologist in a department and a colleague calls you and say, I have a young patient. He has very, very severe pain, back pain, low back pain since 2 days because he was working at home. He carried a couch, something like that, and he cannot move. He has back pain and I need an MRI. The other colleague a little bit later calls you and say, okay, I have also a 20-year-old patient. He has also severe back pain, but he has a little bit more. His pain is not since 2 days, like the first one. It's since many months, 3 months. Continuously the pain is there, and it has some specific things, specific characteristics. It wakes him at the night. It worsens in the morning after waking up. It improves with exercise, and it's a problem if he misses his medicament, his drugs. It comes back, the pain. Now, what would you do? This patient wants an MRI, and this patient wants also an MRI. Exactly, probably yes. And now, of course, the role of this talk or this presentation is to show you that not everyone needs really an MRI, although it's of course better to make MRI or any kind of imaging. It would help you and help the clinicians in order to find what's going on. But you cannot image everyone. You cannot, everyone who comes in, okay, to the CT or MRI and so on. If you do, or if you would do, there might be much waste of resources because it costs much money, and you might also find things that are not responsible for the symptoms now. And the surgeons say, oh, this is nice thing, let's make a surgery, which might be not very necessary. And of course, some patients say, oh, why the doctor is ordering MRI for me? Oh, I must have a big problem. And then they get fear. It's a complicated thing. On the other hand, you are a doctor, you want to know what's happening in the patient, you need imaging. You don't like to oversee something which is important, which might be a problem later, and which I might see now in the imaging. And some patients feel also neglected from their doctors if they don't get imaging. The patients say, I want imaging if it's good. If it's not, I want it, because only so I feel me good. Yeah? And this is really a dilemma. That's why there are some rules, some guidelines that help to choose. For me, as a radiologist, I choose, of course, not the clinical things, but the radiological things. It's nice to smile to the camera. Thank you very much. So let's go on. This is a nice image in Lancet before 2 years. It's a nice article, and I advise you to read it. Where does the pain, back pain, comes from? They make it easy. There is muscles, there is bones, discs, nerves, and of course ligaments. Nothing more. It's easy. And it's really not so complicated. In more details, the pain is in about over 90 to 95% is non-specific. Non-specific means it's a muscle pain. If it radiates, then only in the buttocks, and there is nothing which makes it worse or alleviated. About 5 to 10% of the pain is a radicular pain, which means it radiates under the knee. It might be unilateral or bilateral. And in the very few cases, it's a specific pain. Specific pain, there are specific characteristics of the pain or specific symptoms and signs with the pain which make it specific. And these are the mnemonics of these symptoms and signs for specific pain. In short, a tuna fish. And what does that mean? A typical pain, which, for example, comes in the night or had a sudden onset, if there is a trauma, if there is unprecedented, unexpected loss of weight, if there are neurological symptoms, if the age of patient was a little bit old or young, if there is fever, if there is intravenous drug use, steroid use, or history of cancer, especially prostate, breast, kidney, thyroid, lung. Why these 5? Because these tumors metastasize to bones and especially to the spine. And they are called also PB-KTL, and this is a lead kettle. PB is lead, and KTL is kettle, and this is the lead kettle. But this is not our mnemonic, but it's a tuna fish. These are our signs and symptoms which we have to look at and consider by examining the patients. There are many red flags. There are about 119 symptoms and 44 signs that are present and help. Sometimes do not help because there is no evidence that they are good enough for for helping us, for leading us, and but they remain the best tool. You know, we don't have any other tools in order to have suspicion or no suspicion that the patient might have a serious condition or not. The pain in general can be a mechanical pain, can be mechanical pain that means bone and muscles. Systemic pain, which especially means neoplasms or infections, and referred pain because there are many other diseases in the body which also can cause back pain. And under these diagnoses, there are many sub-diagnoses. They are here printed and also with you on paper, but we are going to take a look as radiologists only on some of these for us red flags or important things which we have to always see. So we are going to take a look at degenerative diseases, compression fractures, neoplasms, and infections. Inflammation also, for example, ankylosing spondylitis, but this is a chronic situation, and almost always the patient has his diagnosis before he comes to us radiologists. It's not a radiological diagnosis. So all these might make neurological involvement, a compression of the cauda equina or of the spinal cord, and that's why they are important. That's why they get visible actually, because the patient has specific pain, and if you have these problems or these symptoms of cauda equina compression or spinal cord compression, MRI in this case is actually an urgent. It's a emergency. If your patient has a flaccid paralysis and diamond reflexes, think always an cauda equina compression. On the opposite, if there's increased tone and hyperreflexia, think about spinal cord compression. Also the symptoms, for example, saddle anesthesia or bladder dysfunction or severe progressive neurological deficits in both legs is always alarming. And on the other side, if the patient has reduced power and motor weakness and progressive severe back pain, think about the compression of the spinal cord. So let's start with from the beginning, degenerative spine conditions. I'm going to make it very short because the time does not help us. But these cases are only red flags if they make a compression of spinal cord or equina or cauda equina. You know all about disc herniations. I'm not going to take much time about it, but only take care when you look at hernias, not only in the spinal canal, but also in the neuroforamina, just like here on the sagittal or axial plane. Many forget to look in the neuroforamina. This is important. And of course, look not only in the spinal canal at the level of the disc, but also upwards and downwards, because some might migrate or even they get sequestered. They get cut off of the original disc and they make a sequester. Always there is enhancement, a peripheral enhancement of the discs. That's why one should not say, oh, I have a tumor or this is an abscess. It's normal that hernias have a peripheral enhanced. Spinal canal stenosis, it can be mild, it can be severe, it can be acquired, it can be also in rare conditions, rare situations, it could be congenital because the pedicles are shorter than normal. That's why the spinal canal gets smaller, and of course here any small hernia could make severe symptoms. Spondylolisthesis, it's also something I think you all know, but when you have such a patient, take a look at the neuroforamina also. This is a normal one, and here where the spondylolisthesis present is, you have to look about the neuroforamen and see if the neural nerves or roots are compressed or not. And if you make MRI, of course, you might see this subchondral edema, which means that there is active situation there. Also, there's a pseudo spondylolisthesis, which means due to degenerative problems of the facet joints, there is no spondylolysis, and there is also the other way, retro spondylolisthesis, because of the degeneration of the disc itself. This is what also rare, but you find it from time to time, which is a cystic lesion coming out of the facet joint. It's a ganglion, actually. It's a benign thing. It makes nothing. But unfortunately, it might compress the dural sac, and it might cause a complete or almost complete compression of the dural sac, and of course, Cauda syndrome. And this was interesting, this case, because several days before this image here, the patient got an operation, disc operation, and 3-4 days thereafter, he got more symptoms after the operation. The surgeons were happy, okay, everything is now good, and 4 days later, boom, we have a catastrophe, a complete Cauda equina syndrome. And this was actually the case. You know, one thinks about bleeding, hemorrhage after operations, but not such a thing. But it can happen also post-operative because of the too much stability in this joint. It makes instability in the joint's upper or downwards. Bastrop's disease is also something which is underdiagnosed. It's more often present, but we don't look there because when we look at the spinal canal, but we don't look behind what's behind. We mean it's only bones, yeah? But these bones, this processus spinosus, due to generation of the disc, they come closer and closer and closer, and to some point they get together, and they make almost a pseudo joint. And this pseudo joint, when patient moves, it's very painful, and if you make an MRI, you see that there is a subcortical edema, and this subcortical edema also enhances, which means also an active process. Let's go to the compression fractures. There are several compression fractures. The most common one is the trauma compression fractures. After a trauma, clear trauma, there is clear fracture with edema, bone marrow edema, with fracture sometimes of the dorsal wall of the body. In this case, I think you know all about that. In this case, it's important to see what's going on with the dorsal wall. If there is a compression of the cauda equina or spinal cord, and if there is intramedulla hematoma. Blood or hemorrhage in the spinal cord is the most worst prognosis. If it's present, it means bad prognosis. And yeah, this is the most important things. And of course, as said, if there is a compression of the spinal canal, of the spinal cord, and if compression is there, see, is there edema, is there myelopathy in the spinal cord or not? This is here one of the most important questions we get. The patient has a fracture, a compression fracture, a wedge form body, vertebral body, and now the clinician asks us, or asks me, is that a benign or a malignant fracture? Is there a metastasis? Is this fracture due to a metastasis or only osteoporosis? And I say, I look at the dorsal wall of the vertebral body. If this wall so angled or repulsed, especially the upper angle, it's repulsed inside the spinal canal, it's always indicative that it's not tumor. The second thing, if you want to give contrast material, there is no enhancement. Also important, the fracture, osteoporotic fractures do not involve the pedicle. The pedicles and the posterior elements are intact of the spine. It's only in the body. A second thing, sometimes it's not very wedged, the vertebral body is not wedged or much wedged, but you can see a line inside. And this line is the fracture line, and if you see it, it cannot be a tumor, due to a tumor. So these two cases actually are clear that they are osteoporotic compression fractures and not otherwise. And otherwise is this case. This is a broken body, it's aclear, but it's not really wedge formed. And there is something interesting that the walls of the vertebra are bowing out. They are not angled, they are bowing because there is tumor inside, and tumor is soft, and when it breaks, it does not break with angle, but it bows out due to the tumor. If you give contrast material, the tumor is going to enhance much. And you see here, this is a renal cell metastasis, and you see that the tumor is in the body and also in the pedicle and also in the posterior elements. And of course, there is a strong enhancement and sometimes also out of the perivertebral enhancement and soft tissue. And this soft tissue is seen in this case. But here also we have a fracture. It's broken body, and the walls are bowed out, but there is no enhancement in the tumor. Actually, it's also okay because of necrosis and so. But you find that the tumor, the soft tissue tumor parts, are around, are perivertebral. They might also go, or not might, they go in the pedicle, both pedicles, and in this case also epidural. They infiltrate in the epidural space. This is another case of broken vertebral body, but it's due to a hemangioma. It's an aggressive hemangioma, which is T1 and T2 hyper intense with a net-like signal, and when you there's also a strong enhancement, strong inhomogeneous enhancement, and you might also see some epidural components and also paravertebral components, and this is from the how it looks in T1 and in T2. It's always indicative that it's a benign thing, it's a hemangioma and nothing else. To the real tumors or to the neoplasms, the most common thing, the most common tumor which you find, about 80-85% in the cases, is a meningioma, a tumor of the meninges. It has wide contact to the dura, and it is inside the spinal canal. It is inside the dural space, but outside of the spinal cord. And how can we say that it's intradural? We look at this space. I don't know if you see it here, at this space. The tumor is growing between dura and spinal cord. And when it grows, the space above or underwards is going also to grow. And that's why I can say, because this place is widened, I can say this is an intradural but extramedullary tumor. And of course, meningiomas usually enhance very much. They can cause compression or a complete compression of the tumor, of the spinal cord, and always look not only sagittal but also axial. Meningiomas do not go in the neuroforamina. If you see a tumor going in the neuroforamina, this is not a meningioma. This is a tumor which is actually specific for young people, under 20, under about 15 years old patients. It's a so-called sausage. It's really a sausage-like tumor, which can be found in the lumbar spine from, I think the battery is out, which is, you can find it here till downwards in this place, and it's always so sausage-like, and it enhances very, very much, and it causes, of course, a compression of the dural sac and make the symptoms. The major symptom in this case is also pain, low back pain by a child or a young man, 15, 16 years old. It's always alarming, and you cannot say, oh, you played too much today in the school or something like that. MRI could be, in many cases, interesting. The other also rare situation, but it's always, from time to time, you can see it, which is the epidermoid cyst. It's a tumor, small or large. It could be found everywhere in the spine, especially in the lumbar spine after lumbar punctures. It's a problem after lumbar punctures sometimes, and sometimes it's there. It's inhomogeneous in T2, in T1. It has no enhancement. Actually, if you see that alone, you cannot say exactly what it is. You can think about epidermoid, but you need a clue, and the clue is the diffusion-weighted imaging, which is very, very wide. And this is actually characteristic for the epidermoids. Also intradural are metastases, drop metastases from the brain tumors. They are small or nodules. They might be mass-like, and they might be in sugar coating form, which is very extensive. Extradural tumors, which come from the bones, actually, and they go inside the spinal canal. There is a very, very big list, actually, but the most important and the most common are these here, and the most common of these are metastases. In about 90% of the cases, it's metastases, and hemangiomas in about 7%, and all others are the other things. In the body in the vertebral body, you find these tumors: hemangioma, giant cell tumor, chordoma, lymphoma, and Ewing sarcoma. in the posterior parts of the spine, you find osteomas, osteoblastomas, and aneurysmal bone sites. Some tumors like metastasis, chondrosarcoma, osteosarcoma, multiple myeloma are everywhere. And let's take some examples. This is a lymphoma. Lymphoma, plasmacytoma, actually all tumors have something common, almost something common, which is enlarging the vertebral body. The vertebral body becomes a little bit larger and bowing out to the outside, and it enhances, and it might have epidural components. It also goes through the pedicle to the backside, to the dorsal elements. It might cause also compression of spinal cord, and in CT it's an osteolysis. This is the normal thing by actually almost all tumors of the spine. Whether it's lymphoma or plasmacytoma, like here, plasmacytomas also begin with the vertebrae and vertebral body and goes actually everywhere it likes. If you find more lesions, then it's multiple myeloma. Yeah, it's the same actually like the other tumors. Also, chondrosarcoma is not different. It's also tumor that enlarges the vertebra. It takes it shows a big strong enhancement, but after enhancement here you find that it's not homogeneous the enhancement. It's there are many spots inside. It's just like a reticular enhancement, and this is due to hemorrhage, due to matrix calcifications and these things. The other tumors, what we saw, they are almost they have homogeneous enhancement, and chondrosarcoma has inhomogeneous. Osteoblastomas come from behind, and they are either focal tumors going outside majorly from the pedicles, or they are also here the tumor. It looks as if it's diffuse, growing everywhere, but the tumor actually is this one, and everything this enhancement is its infiltrative growth, and that's why when you see a focal tumor behind or a diffuse tumor also coming from behind, especially from the pedicles, think about osteoblastomas. Metastases are also the same, just like all other tumors of the spine. They might be focal, small, big, and they might be complete. They can overtake the entire vertebrae. You see it very nicely in T1, which then it's hypointense and the in hyperintense. And when there is no enhancement in the tumor itself or in the vertebral body tumor part, you find enhancement around perivertebral. And of course, in many times you find this enhancement or soft tissue growing within the spinal canal. Osteoma is a special case. Sometimes they say it's small and fine. This thing is small but not fine. It's small, not easy to find, even if you make CT and MRI without contrast enhancement. And it's usually, as said, in the posterior parts of the vertebrae. And it's actually the tumor itself is this white point. Osteomas have three parts. The first part is this nidus, and this is the actual tumor actually. And around it there is a fibrovascular rim, and around it, on the around it there is a sclerosis zone, sclerosis surrounding the lesion. The lesion itself, you can find it in MRI, and even the needles is sometimes not seen in CT. This rim, which is the fibrovascular rim, enhances very much after giving contrast material, and this sclerosis area around the tumor also can be seen in T1 and T2 actually very, very nicely, actually in CT also. But in this case, it might be difficult to see the sclerosis because the area is small. See, here is normal, and if you take a look at the images so quickly, you might oversee this small tiny thing, although it makes really much pain. We go to the infections. Spondylodiscitis begins actually in this part, in the end plate. The end plate gets a little bit edema and it enhances, and this is actually our clue that this case is problematic. Further, the disc is hyper intense, is strongly hyper intense in T2 and in steer, and it's called also hot disc. That means when we see hot disc and a little bit edema and enhancement of the even if you don't see enhancement, edema in the end plate, you have to give contrast material in order to see to what extent is the problem. And this is actually the quite standard look of spondylodiscitis. Of course, several days or 1 week later, the destruction goes on and the disc goes down, and more bony destruction happen, as you see on the right side here. Spondylodiscitis might be found in only one segment or on several segments, but it looks the same: hot disc and edema in the end plates. And when you see several segments at the same time, one should consider if it's tuberculosis. This was not tuberculosis, but this one was tuberculosis, making a severe destruction and fracture, compression fracture, infective compression fracture of this vertebral body, of course with epidural components. And this is also TB, polysegmental, with much destruction of the bone, and with also much epidural components with also abscesses inside, also epidural abscesses, I mean, with compression of the spinal cord, and it's a catastrophe. In this case, it's cervical spine, which is not our our subject, but it's not always. You cannot find such a everyday such a destructive case. Excuse me. Also, the spondylodiscitis might make an abscess, which is a fluid part with epidural fluid part here. And of course, when you see a fluid with hot disc and edema in the end plates, it's always what should it be? Anything else other than abscess. And if you give contrast material, you see here the peripheral enhancement, and if you want, you can do also diffusion weighted imaging and see the characteristic signal of abscesses. But it's already here and here clear. What should it be? Anything else? Epidural abscesses can also be found without spondylodiscitis. In some cases, like this child here, I think he is 13, 14 years old, and he has severe back pain, fever, and night sweating, and several characteristic symptoms. And in MRI, because he's young and he has fever, back pain, severe back pain, on the outside, it was also there is something growing on the back. It was clear that there is something going on. And in MRI, there was this fluid collection, epidural, and here you see that it's epidural. Why? Because this dura space is not widened, but it's tapered, because the lesion is coming from outside of the dura. And of course, the diffusion-weighted imaging give us the evidence that this is an abscess, epidural abscess. Also, there are several other things which might make a compression of the spinal cord, like hematomas, epidural hematomas, which can be clearly seen that they are epidural because of the tapered dural space upside. And of course, when you make several days later, you can see that the blood is becoming white, becoming hyperintense. In my talk tomorrow, I'm going to talk about when it's hyperacute, when it's acute, and when it's subacute hemorrhage. Subacute hemorrhage, which is methemoglobin, is white, and this is actually a clue that it's a hematoma. Lymphomas, they don't enhance bleedings. Excuse me. Hemorrhage does not enhance, but if what's here thought to be fluid collection, and you are not sure because it's so hyper-intense and so not really hypo-intense in T1, it's not clear whether it's hyperacute blood or acute blood. Okay, we gave contrast material, and it was enhancing. It's a soft tissue. And this was a lymphoma. And with lymphomas and with melanomas, there is nothing what you cannot see. They can make anything. Lymphomas and skin cancers, they can make any kind of signs of radiological forms. This is a rare situation, but it's still a little bit complicated because no one knows what to do about it. It's actually a semi-acute situation where the spinal cord gets herniated, almost always a ventral herniation through a defect in the dura, and it remains caught inside. And the spinal cord gets compressed, of course, in this dural defect, and it does not come back from alone. And this case, if you are going to wait weeks, you might get the spinal cord defect due to compression myelopathy. Many say, okay, I have to operate on it. Many say, I want to wait and see. There are still no clear definitions. What should one do? Surgeons like to operate it, and I think if one has such a thing, it needs a treatment, because sitting in wheelchair is certainly not the best thing to do in this case. So this is actually called a TISH, thoracic idiopathic spinal cord herniation, because it's almost always thoracic, in the thoracic spine, and it's almost always ventrally. In summary, if you have a patient with back pain without red flags, wait with the images. With imaging, wait 3, 4, 6 weeks. And then if the pain is still existing, you can make imaging. If they are Cauda-Equina syndrome or spinal cord compression, immediately MRI. If you have a patient with one or more of these tuna fish symptoms and signs, don't hesitate in imaging. Don't tell him come back next week or several weeks later. Don't hesitate, and if you want to make imaging, then only MRI. Just start with MRI in these cases. If MRI not possible, then CT. Don't rely on radiographs. Radiographs don't help in these cases. And always think about these 3 things: compression fractures, about infections, and generally speaking, space-occupying lesions, which might be a hernia, which might be hemorrhage, which might be also a tumor. Yeah. At the end, I say, I hope you are still awake, and wish you best luck and best wishes for the whole course. And we see you tomorrow. We see others tomorrow.